everyone. I'm seeing that it's 1 o'clock. So I will go ahead and get started introducing Dr. Hilt. So I am super excited and honored to be able to introduce Dr. Hilt today, a personal icon of mine as a person also trained in pediatrics and child psychiatry and interested in that education of pediatricians. So not to delay any further, Dr. Hilt is a professor of psychiatry at the University of Washington Department of Psychiatry and Behavioral Sciences and Seattle Children's Hospital. 16 years ago, he started the Partnership Access Line, a child mental health consultation service, which now serves all primary care providers in Washington, Wyoming, and Alaska. He also directs Medicaid, medication, second opinion programs for Washington and Wyoming, and psychiatric consults for Wyoming's foster care multidisciplinary team reviews. He has helped to develop several collaborative care programs, school support projects, and set up a statewide mental health referral service for all parents in Washington state. Dr. Hilt's primary interest is to increase professional collaboration between mental health specialists and pediatric medical providers, as well as improving family access to high-quality mental and behavioral health care. Dr. Hilt came to the field of child psych after an initial short career as a general pediatrician. His inspiration for retraining to be a child psychiatrist was to help address the need for mental health care that he saw in his pediatric patients while working as a general pediatrician, and the inability to get any of his patients in to see a psychiatrist when they needed one. So without further ado, here is Dr. Hilt.
Hello, thank you very much. Yeah, I've been at this for a little bit, and hopefully today I can share a few things that would be helpful for all of you as you think about new areas of and avenues of consultation, because it's a big field out there and a lot of need. And we all want to, oops, I'm clicking, making sure I get the slideshow launched. There we go. And I think that looks good. That there's a lot of opportunity out there for us to help. So first of all, disclosures, I don't have any financial relationships with commercial interests, so that makes it simple. So I'll go over a number of the different things we've done out here in the Pacific Northwest, and importantly, wanting to share things that didn't work, along with things that did work, because I think you learn as much from the failures as you do from the successes. Have some data about some of these experiences to share, and I'll talk about advocacy strategies along the way. So basically, I might be preaching mostly to the choir here, but there's not enough mental health specialists to go around for the service needs that exist. When it comes to kids, the data reports have been somewhere around a quarter to a fifth of kids who need mental health care will ever, in fact, see a specialist. There's a big geographic discrepancies for where people are located. I included a map of the state of New Mexico from the American Academy of Child Psychiatry that shows everything that's in red is a county that doesn't have a child psychiatrist, and there are no areas of the state that are considered adequately staffed for that particular specialty. Then there's also insurance issues, so you want to see somebody well, but do they accept your insurance? No, they don't. So, we're woefully underrepresented. The average age of a child psychiatrist, again, per ACAP in New Mexico, is a little bit older than national average, which is 52, I believe. This is a picture of me a few years ago when we first were doing lots of telemedicine with dedicated equipment. I was very excited about this, but pretty quickly realized telemedicine by itself just changes the address of where your patients are. You do a little bit of robbing Peter to pay Paul with telemedicine alone. So I became a really big advocate for using it for education or for consultation, we don't solve things just by tele. As general topic categories of the different ways you can help with a limited workforce, education is one of the big areas. So yes, you can give presentations, you can provide education to primary care providers through care support materials, handouts that they can give to patients, some easy, simplified books that parents could read. You can do teleconsults for primary care. I do both elective and mandatory, as it turns out, consultation. So that's another way of doing things. You can have care managers, and this is part of the collaborative care model to have office-based care managers that could provide some additional support for families and communicate with a specialist about a caseload. Also, you can have centralized referral assist. I'll go into that, or brief interventions. So I'll go into some ways that we did brief interventions as a way to take a given workforce and have it stretch further in terms of impacts. So I've always liked the telephone because there's never really much of a communication, a technology barrier with the telephone. Sometimes calls get dropped from our cell phones versus landlines, but otherwise you don't have to install anything on a computer. You don't have to go to training sessions to know how to work a phone. And I really like telephone for being able to create teachable moments. The moment a primary care provider says, I want help with something for my patient, and you talk with them about what's going on with their patient, they learn something that's going to stick because they apply it. It's a teachable moment. So it's really the bedrock of all our medical education system. So that provider to provider communication about a given patient really pays dividends over the long term. And Massachusetts, where I did my child psychiatry retraining, part of why I picked that location was because at the time they were starting something called TCPS, or Targeted Child Psychiatric Services, that was kind of playing into some of these ideas I'd had of, well, we should have child psychiatrists consult to primary care. What they did was have a phone access line and a brief treatment. So it's sort of a treat to stabilize, and then we'll send them back. And that pilot basically didn't work in the way that it had a clinic that just filled up just like every other clinic, and then they couldn't discharge patients out of there, even though the primary care provider said, yes, we agree, this is just a treat and stabilize, and you're sending them back. That was really hard to get rid of patients, essentially. That evolved into something that's called MCPAP, or for the Child Psychiatry Access Program in Massachusetts. And that was fairly robustly set up with, at the time, 6 different regional teams. As you swing a stick in Massachusetts and you hit a medical school. Each team had their own child psychiatrist, social work, and administrative assistants. So when I went out to Washington after finishing my retraining into child psychiatry, I said, Washington needs it a whole lot more than Massachusetts does, but it took a couple of years of advocacy to get something going. So a lot of people to talk to, getting something through government takes time. So talking with university and hospital government relations people, different professional organizations, our state pediatrics chapter happened to be fairly influential with certain legislators, so they were a key ally. Talking to leaders of various state agencies, different advocacy groups. It's a very complex story how we got things off the ground initially, but some of the other things I learned is when you talk to legislators, they're not the crowd that you bring research articles to in big, long discussions about why you need to do something. You got to be able to boil it down to emotional stories and maybe something like a 1-page. That's what carries the day when you talk to legislators. So that was something I had to learn the hard way against. So when we created our PAL program, our state Medicaid medical director was an ally because it already started working with them on second opinion medication review service. Rarely when you go to legislatures does things work on the first attempt. You usually have to take multiple bites at the apple. We got lucky. We had a good support even the first time we asked. So that started in 2008, and then a few years later, once we had it up and running, Medicaid directors talked to each other, and so that's how we got connected to Wyoming and created some programming for there with some unique attributes. And with the HRSA grant, we started a program for Alaska in 2018. So access lines are not all the same. They all get constructed a little bit differently depending on what priorities are, and frankly, funding is. And this is a slide I did years ago to show how we had to change things, why we had to change things quite a bit relative to our model, which was Massachusetts. That the geography of Washington State was incredibly different than Massachusetts. We had less money to use. We couldn't do things the way they did in Massachusetts. We had to come up with our own way. So no in-person sign-ups where we're going to meet people over the lunch hour, because it'd take me a full day to get over to Eastern Washington and back just to have a 15-minute meeting with people. And we also had to operationally link with other things to have more efficiencies. So an access line, people will do it as a warm line where you like, oh, let's leave a message and we'll call you by the end of the day. We wanted to prioritize live answer as much as possible so that when the provider has a question, they get somebody almost always right away. And it's very difficult to do that in startup if you only have like one person, because you might be on a call, you might be eating lunch or need to use the restroom or something like that. So it really helps to have more than one provider on duty at a time to be able to perform with, almost always when I call, I can talk to somebody right at that moment. So we operate it kind of like a hotline at this point. We had to have a social work assistant for finding resources, because a lot of times primary care providers say, well, where can I send them to get this? So that was a key component, and it is in most of the access programs that have grown over time. And we also prioritize early on sending follow-up notes. This is not something that's universally shared amongst access lines that have grown since. A lot of them say, oh no, we're just a general education service. We're never giving any patient-specific advice, when the conversation is basically always patient-specific. And we know that a provider is writing in their chart, I talked to Dr. So-and-so and they said this. So we just close the loop and make sure that we send a note to the provider that says, if I recommended clonidine at 0.1, the provider on the other end didn't write down in their own notes clonidine 1 milligram, for instance. So, and it's also a reference point they can look at later for, if this didn't work, then try this later. We settled on, we wanted to do some educational events for our providers, and then learned that became really important for meeting providers and starting that word of mouth and encouraging people to use the program. So we currently do 4 a year for Washington, 2 a year for Alaska, 2 a year for Wyoming. As soon as there was going to be more than consultant than just myself, we have to acknowledge that in our profession, psychiatry, there's a lot of different ways of doing things, a lot of different opinions. So I knew as soon as we were going to have more than one psychiatrist, we'd have to have some sort of fidelity manual and evaluation so that we can be consistent with each other and not give different advice depending on who you talk to. So it started in writing a fidelity manual. I thought, well, might as well make this written for the primary care provider at the same time. So that became our care guide for primary care, but also serves as a fidelity manual. And that includes things like patient handouts that we suggest they use, depression books and videos that families can look at, disruptive behavior issues and the like. Getting a primary care provider to try anything new is not inherently going to work. So, creating this program, we had all these like mailings, and we even sent out refrigerator magnets with our number on it and things like that. And, that was pretty ineffective. What was effective is talking to people at our face-to-face meetings and word of mouth. In the early years, we realized, if we start asking people, at least more than half of the people who called us said they heard about it by talking to a colleague. So you have to get to a critical mass where people are telling each other, hey, if you have a problem, call this. Somebody you trust tells you to do that. And it takes multiple years to get to a steady state, even with lots of promotion. So some of the other things we learned in trying to set up an access line is that, unsurprisingly, primary care providers take care of really complex issues. We usually can recommend care remained with primary care, often with a therapist engagement. They usually are, essentially, I say they have a script pad in their hand. It's like, what should I prescribe? That's the most common question, but most of the time we're having psychosocial care advice. So it isn't prescribe this as the response in the majority of cases. if you, we get feedback surveys, submit a feedback survey request with every consult call follow-up. It's kind of boring because the ones who use the service really love it, but there's an extremely wide variation in the use of an elective consult line. So we have practices where, one provider calls constantly, and the other providers in the practice never call. So there's a lot of factors that go into this, but you have to recognize an elective consult line will not help everyone equally, for sure. We had problems with our data system, so we started off, just Word file and Excel file, and then moved to different data programs. But we kept having problems where we'd have one or two persons who were the only ones who could fix it when something goes wrong. And so you come in Monday morning and the program doesn't work. It's like, and then if that person's out of town, you'd have no program for the week. So eventually we switched to a company to be able to deal with a database. And for the most part, you can't just log telephone patients into an electronic health record because, like a hospital EMR, because they're not actually the hospital's patients. They haven't been seen that way. But data use, a data program, you can get a lot of mileage out of it and organize things and search and create reports. There's a lot that can be done that way. So another thing I mentioned that I've been participating as a way to consult is medication reviews. And that's not what I thought you could say is a positive effect consultation service, because for the most part, medication reviews is just a bear of all of our existence. These pieces of paper that you have to fill out and there's still denials and nobody learns anything. There's really not much benefit to the patient. But if you do it well, honestly, I've become an advocate for this. So what do I mean by doing it well? So in Washington, back in 2007 is when we started reviewing as a state prescriptions for ADHD prescriptions that are pretty far out of standard practice. So methylphenidate prescription to a child of greater than 120 milligrams a day, for instance, where most people could say, yeah, somebody else ought to take a look at that. That makes sense. We added antipsychotic reviews later in 2009. 5 or more concurrent psychotropics is a flag, 2 or more concurrent antipsychotics are greater than 60 days. So there's a variety of flags that got added over time. We do a pretty significant number of these reviews a year now for state of Washington. And again, if we were to run this just as pieces of paper and reading things, as a reviewer, if you just read records, you would be forced to say no a whole lot of the time, because honestly, most of our records don't support very well why an individual patient needs it. But if you have a conversation with providers, like, oh, I get it now, that makes sense. So we started off doing phone discussions very early for that reason, and that became the only way we do consults. So that became our default. And it's the only opportunity for learning, frankly, for the primary care provider, if that was something that can happen. Consistent messages were a big problem. Our state started off contracting this to 3 different institutions, and despite many efforts, we couldn't get the providers in the different institutions to review in the same general way and have the same message to the practice community. So eventually they said, heck with it, we just want one site, and you need consistency within that site. So, again, variation is not your friend in philosophy when you do a program like that. Positive feedback. We actually learned how to conduct those doc-to-doc discussions in a positive, helpful for the patient manner, and we're not, collecting. We're not out there to collect scalps and say no a whole bunch of time. We're not, getting a bonus based on so many no's like the way the insurance company does. So by doing supportive discussions with provider on what is usually the provider's most difficult to manage patient, we usually get people say, I was looking forward to this call, or, this was really helpful. So we collect feedback surveys after every one of these. And there's some outliers that say, I'm a doctor, nobody should ever review anything I ever do. But for the most part, we get people say this is really helpful to them after learning how to do it well. The problem is it takes a while to get the case to us. So we still have persistent challenges in information processing with the state of getting the case to us so we can get it done. We also learned that just the fact that somebody is observing changes a lot of prescribing practices. So it was surprised to realize how many early on when we first started those ADHD really high dose reviews, just the fact that a provider received a notice like, oh, you have to send some records to say why this is appropriate for this patient. About half of those prescriptions were changed just because of that one notice being sent out. So the Hawthorne effect is very powerful when it comes to review systems, which was an interesting thing to learn. And saying no was not necessary, really. When we combine elective and mandatory reviews, so by elective I mean our PAL line in the state, in addition to these mandatory medication reviews that happen with the same reviewers and trying to have the same general best practice messaging, there was a big change in prescribing habits within a state. So we did a study with the state of Washington's pharmacy division where we looked at the first 5 years of doing PAL and medication reviews, just specific to antipsychotics, which at the time were really expensive to the state, so it was a big deal for them. So we counted over 1,000 antipsychotic discussing PAL calls, elective calls, and 870 mandatory second opinion reviews that involved an antipsychotic, again, which had like a significantly less than 20%. I think this has to be changed recommendation. And this is a time series analysis to show the first vertical dash line is when we started our elective PAL program. Then the second vertical dash is when we started mandatory antipsychotic reviews, and the third vertical dash is when we said, okay, the state's reviewing 2 or more concurrent antipsychotics. And just to show the significant changes in trends that were linked to the implementation of those programs is one way. The net result was after about 5 years, about half as many kids on Medicaid in the state of Washington that were using antipsychotics as before we started all that. So that wasn't coming from saying no. That was a small number of no, this has to be changed, or no, this is inappropriate use. It just, best practice education, frankly. There's another way of doing medication reviews. Somebody that helped me do that time series analysis, we put together a grant proposal for the NIH and worked with health systems of a multi-site trial to do a lighter touch review within an electronic health record, to do best practice alerts for out of appropriate, estimated out of appropriate prescribing, like an antipsychotic for a kid where there's no diagnosis for bipolar, schizophrenia, et cetera, all these guidelines we put together. And then some of those, randomly assigned just a best practice alert, or additionally receive a psychiatrist caseload review, where I said, okay, that sounds, I would have done the same thing, or you really might consider X, Y, or Z, but it was non-binding. So there was no threat of you can't prescribe. There was no stop in the process to prescribe. And there was no verbal discussion with the providers. It was just they got this notice there was a note from a psychiatrist of here's the things you may consider. Essentially, we found little impact on prescribing rates after doing this FYI electronic health record note only approach. You can take that a lot of different ways. You could say, oh, well, this health system was uniformly doing the greatest care ever and nothing needed to change, or there really was no impact of doing these electronic notes. MDT consults. So this is something that state of Wyoming, when we started putting together a consult service for them, they said, we had a particular need that we want you to help with. So their Department of Health had noticed that foster kids were being put in long-term residential placements at a pretty high clip, and were also being sent all around the country. A lot of kids being sent to Chicago and Georgia and things like that. And once they were there, they could be there for a year, 2 years, 3 years, when the reason why they went there was kind of fuzzy at best. And the experience in reality was often, if they weren't causing a problem at the center would say, oh, they need to stay here. And so kids were just kind of getting lost in their placements. And the state was always very under-resourced for child psychiatry. Few, if any, of those kids had, few of the kids had a child psychiatrist evaluation prior to these very long-term residential placements. So they said, help us with this. So we came up with a system of saying, well, the kids in the foster care system can have their foster care caseworker request an appointment with us, a televideo appointment, where we could do one of these evaluations. And it takes a bit of work on the caseworker's behalf to send us some case records of what they have, and get this teed up in the right way. We try to get those set up within a few weeks if possible, because they often have court hearings where these recommendations would go into. We set it up where we talk to the caseworker. I, like as a psychiatrist, talk to a caseworker for about 30 minutes right before meeting the kid after having looked at records, because there's a lot of nuance and story of what's going on. Then we do a usual televideo appointment and create a report and clinical care opinions that then the court in the case and the DFS case office will use for managing the case. So it takes about a half day at doc time to do one patient. So these fairly resource intensive evaluations, and the stories are just awful of what these kids have gone through that are being sent to us to do evaluations. So, frankly, as a child psychiatrist, if I did one of these every single day of the week, it would really contribute to burnout. So we try to only schedule these like once every other day for a work day for our consultants. The judge and the multidisciplinary team remain the final arbiter of care plans. We're just giving, this is what's going on for the kid. Here's our advice, which is important that we're not the final arbiter. It's a different role. Now, the foster care divisions at the state were a little like, who are these people? Why are they going to give us advice about care? And we're extremely skeptical of, there's a difference between the local caseworkers and central DFS office. Central DFS office loved this, but the local workers were like, I don't know. We don't want to give our control back. So I actually went on a speaking tour around the whole state with people from the foster care division. I went to every county and talked to their caseworkers, learned a lot about the state in the process. But then it's like, oh, I get it. Yes, this would be helpful. So kids had unrecognized problems like anxiety, super high complexity. Usually kids are being referred to us for long-term residential placement, about 80% of the initial year referrals, but only about 25% of the time after we did an eval said, yeah, actually that's appropriate. A lot of the time there was a lot of other things that would be appropriate, and we just gave that care advice back to the team and explained, why they should have, outpatient CBT for their unrecognized anxiety, for instance. We did an evaluation with the Department of Health and Foster Care Division looking at what happened to all those kids. So we found out all of their care costs, what happened to those kids. Did they eventually go into residential, need to go into residential later or not? And calculated up all the costs of our programs and actually found a positive financial return on investment, even when you added in the cost of our PAL line and med review system. So we also did mandatory second opinion reviews for the state, and it's found a significant change in prescribing statewide after doing this, with under 5 psychotropics decreasing by about 40% and 150 greater than 150% greater than 150% FDA max decreasing by about 50%. So again, not saying no very often, just providing education to providers. So that's why the state of Wyoming continued to pay for a program like this. So we've done other things in consultation. I'll talk about 4 of them briefly. So the referral assist service, which is mentioned in the intro, that was because we recognized families were really struggling to find a therapist in the state, and it's fairly universal. We were hearing stories of, I've called 10, I've called 20 different providers, and nobody's accepting new patients, and I give up. And so a lot of kids would, have care delayed for years because they just gave up. And the primary care offices struggled. They didn't have, few primary care offices have sick care managers that could actually do all the calling on behalf of the parents. We heard that back in Massachusetts again, William James College set up this program called Interface, where they got contracts from not all, but a lot of the counties in the state to pay for a centralized mental health referral assistance service that, say, in the county, the emergency rooms and other people in the health and the care systems in those counties, they could have somebody on behalf of an adult or family look for an available therapist on the adult or family's behalf. And so we said, that sounds like a brilliant idea. Why don't we do that statewide for kids? So we went to the Washington legislature and asked for funding for it, got it on the first year. but we had to make really big guesses about how often this would be utilized, how difficult, how much time it's going to take for a referral specialist to find somebody, how we're going to set it up, all the data systems. And again, that interface program in Massachusetts had data people that, you know, was a proprietary sort of like one and two person shop thing. So it's like, we don't want to play around with that game either. So we incorporated it in Salesforce. So, you know, it was set up, any parent can call, provide education, find out what their insurance location, skill interests are, and try to find at least two available options for the parents. And they have to call because people don't, you know, make appointments based on a third party request. It should be the parent doing that. So we are these days getting over 100 requests a week. During the pandemic, it was extremely difficult to find available care. We were often calling with commercial insurance up to 20 people ourselves, trying to find one person with availability. In some plans, we just, you know, in some locations, we could never find somebody who's available and had to instruct people to complain to the insurance commissioner and their health plan. We had to increase funding multiple times as this thing grew. It takes, these days, one FTE of a referral specialist maybe matches around 40 clients a month. He had no idea what that ratio would be going into this. For those of you who don't know, about half nationally of kids are on Medicaid programs. Same too in state of Washington. In our place, about 2/3 of parent requests are from commercial insurance. So it's in the state of Washington, it's harder to find a therapist if you have a commercial health plan provider than it is to find a Medicaid health plan provider. Families may not like their local mental health agency, but they at least have it available. We do outcomes that, at 2-week follow-up. That's weird. There's like a diddle that's coming on the screen. Anyway, at 2-week follow-up, there would be extremely positive feedback from the families because we make a request for feedback. Do you guys see the lines on the screen? Okay, let me stop share for a second and see if it'll clear off the lines. I don't know how those lines are appearing. Okay, oh, there we go. I'll try to make it work again here. All right, I think that reset it. Can you all? Oops. Try again. And okay, so the little lines are gone now. Sorry. Okay. So in the outcomes of a referral assist service, there's a 2 weeks after we make a referral recommendation to a family, we send them a follow-up survey, and they don't all fill it out. But those that do said, most of the time, not always, succeed in making an appointment. We ask them for feedback why it didn't work, so we know that as well. They usually said that they've been searching for months before calling the team, and they really appreciated it. This is a chart of the rate and growth of calls over the first 2 years. And then after 2 years, we reached pretty much a steady state that we've held ever since. So it takes a couple of years to get a thing like this known and to grow and figure out how to run it. Here's something we did for schools. We wanted to have a way for psychologists to consult the schools from our university. And so we put together something we just called PAL for Schools, but it was really being operated in a different way. So I partnered with Elizabeth McCauley, our lead school psychologist partner here at the university, and came up with a plan for for social workers in the schools to get weekly case discussions with one of our psychologists to kind of go over the most difficult to manage students that they have in the school. We also had the plan to provide trainings on desired topics from the schools and set up that, we can do a televideo consult with the student themselves after one of those discussions, if that was appropriate. Basically, as we ran a program like that in the state of Washington, again, with our state legislature's funding to pilot this, The trainings were very much liked, but teachers get tons of training. So the people that received the training and benefited most from it was like the counseling staff. We did get some teachers, but it's hard to get their attention. And there's also a dynamic where teachers say, you know, don't ask us to do mental health care. We got so much on our plate that you have to be aware of when you start doing this sort of school-related work. The schools themselves, there's this thing called MTSS, or multi-tiered system of support, that schools are supposed to have in a consult program like this about the district's most difficult patients or students. Hits what they call Tier 3 MTSS, which is difficult for schools to fulfill. So that became something they specifically valued. And the televideo appointments with patients, with student patients, we only did one of those. It really wasn't the valued part of the program. And we did so much work to try to set up systems for doing these televideo evaluations in the schools and consents and running it through committees. It is not something I would want to repeat. The case conferences and staff trainings are easily scaled, and we figured an FTE worth of psychologists could support 20 different schools. Problem was that we couldn't hire enough psychologists to do this if we wanted to go statewide. And we also can't pay enough at our university to attract the psychologists to come in and do this en masse. So this was a pilot that we couldn't follow up statewide, unfortunately, when it came to reality. FAST, or first approach skills training. This is something that we grew out of a only partial success, we'll say. So because collaborative care requires having a care manager in a practice, somebody who can kind of be based there and track and follow patients, we knew as collaborative care was coming out to the rural communities or pediatric practices in general, a lot of practices are small, and particularly in rural areas, it could be a single or two providers, and you can't really have a care manager who does this stuff a lot in a 1 or 2 person practice. So the idea with the state was, what if we had a shared care manager role? And let's add on to that shared care manager role something good, like brief interventions. So I challenged a couple of psychologists that work with me to boil down evidence-based practice for just 2 different conditions that we said, let's focus on those 2 and study the impact that we can have for depression and disruptive behavior, depression for adolescents and disruptive behavior issues for younger kids. So we put together a 4-session protocol because nobody had done that. Surprisingly, it was something we had to create de novo. Basically what we found out is that, do I have this on the next page? It was difficult to get the right referrals or to even get referrals. So the providers in the community said, oh, yes, we want this, we want this. And then they sort of didn't refer. We knew they had the patients, but we couldn't get referrals very easily. And those that were referred were very often like, oh, they've been out of 5 different residential treatment facilities and they've been in care for 5 years. So the brief intervention for depression, that's not really what it's suited for. So a lot of the referrals we got were inappropriate. And that kind of feedback to the primary care provider, discourages further referrals. But the 4-session model for those that were appropriate and actually did it worked. The families liked it. They said it was enough treatment sessions for the most part for those issues. We found improvements in rating scales of disruptive behavior and depression rating scales and the like. So we said, okay, we've got something good out of this, even though the regional referral into collaborative care didn't seem to work the way we wanted. So we turned it into something else. We call it FAST, or first approach skills training, and got more funding for it. And we've been training therapists in the state of Washington. First, the idea was it was going to be just therapists based in primary care offices, which there have grown to be quite a few now. And then we had mental health agencies say, well, we want our therapists trained to do brief interventions too. So we've expanded. So there's 6 different modules that we have now. We've been putting things on the web because we're a university, we want to share information, and there's a number of research partners we have around the country in doing this. So we made lemonade out of lemons here. Is basically what I want to say. So it includes things like our workbooks have things like parent handouts and guides for the therapist and things you could hand to kids while you're working with them on brief interventions. So this is what it looks, some of what the website looks like for first approach skills training. We also got a grant to do crisis consultation service as an add-on to our PAL program. And this became at our hospital during the pandemic, the ED volumes are crazy. We had so many kids that had like suicidality and didn't know what to do with, where to send them. They had no follow-up for them. So we created our own at Seattle Children's, a 4-session crisis intervention service set up with both the parent and child would get essentially simultaneous individual therapy and kind of connect together, and the real focus on shared care planning and getting through the crisis, and had been finding that that would work for a lot of these cases out of the ER, but in Eastern Washington rural areas, they had no access to something like this. So that was the idea of the grant. So on the other side of the state, we work with the mental health agency to be our therapists, our regional based therapists, and thought, oh, we'll get a PAL call. And then if it's somebody with depression, suicidality, and they don't already have a therapist that's helping them, or it's beyond what the therapist can do, we can refer those cases into this regional crisis clinic. And what we've basically been finding in doing this is, again, we've had a real problem getting the actual referrals from the primary care providers, despite them saying, we need this help, we need this help, we want, they end up just saying, somebody's suicidal, go to the ER. Rather than refer into this brief crisis intervention service, despite us continually reminding about it. So eventually we said, okay, fine, let's talk to the crisis programs in the ER. So we'll get them to refer because we don't have a resource that's not used. And similar to, even if it's, if the service is a crisis service delivered via televideo, we've been getting good outcomes for those that get referred in. Collaborative care, University of Washington is the home of adult depression collaborative care. And I just want to have a slide in here to acknowledge I refer to it as capital C collaborative care, because there's lots of different ways of doing collaborative care. And, one which involves a care manager who's doing a registry and doing weekly check-ins with a psychiatric consultant and managing caseloads and doing a treat to target with PHQ-9s, PHQ and GAD-7s. That's the classic model. Translation of that model for kids is a challenge because essentially kid issues don't boil down to two neat little brief rating scales. I just want to acknowledge that there's a lot of variations. I participated in a number of them out here. That collaborative care is great, but for kids it does need to be adapted. One of the adaptations we tried actually with some medical colleagues is doing this for concussion care, believe it or not. So kids that were in a medical scenario, let's try doing collaborative care with CBT for depression or anxiety for kids going through chronic concussion management as an add-on with an in-office care manager. And we did a pilot study and found, lo and behold, that helped. Kids had significantly improved post-concussive symptoms by doing that, 13% in control versus 13% were still having high level symptoms after getting collaborative care. 42% in usual care were still getting high level symptoms 6 months later. A lot of things that look good about this. And then we did a larger study with NIH funding and then found far less robust results. And it's partly, and we've interpreted as because we did some different things. We didn't have in-office, a nice controlled system in-office providers. We had televideo provided collaborative care and care management, and there was less focus on the parents doing the care management and educating and supporting parents to do care management. So it was a little bit different. We did have some statistical significant changes, but it was far less robust. So kind of learning with collaborative care, having that hands-on approach and focusing on the right target, you could spend a lot of time and effort and it doesn't actually move the needle. We've also tried something else unique, tried to direct to consumer consults through a large employer. So at Boeing, we did a contract at the university with Boeing to provide a line for their members. They're huge self-insured providers, where either a patient or a parent could call, and the idea was kind of tipping the pyramid. So usually it takes a lot to be able to access a high-tier specialist. They say, well, what if we just said you can have a phone call with that high-tier specialist right at the outset, and you can get some advice about what to do, and how would that be impactful and how well would it be used and the like. What we ended up doing with this, giving this number out, it was, answered by a care manager for this program, and then they would distribute it to a psychiatrist for a callback and scheduled callbacks. What we found is that most of the times it would just result in say, yep, you need to see a therapist. Let's have the care manager find a therapist for you. There ended up being not as much value to this. I did all of the child cases in this program myself. And, once in a while, I was able to really give some good upfront advice. But, as it evolved over time, it's like, yeah, we need to find a therapist. And they told me I had to talk to you. It's like, okay, well, I'll tell the care manager, find a therapist for you. Good. So it ended up being stopped because it wasn't as impactful as we thought it was going to be. Juice not being worth the squeeze, so to speak. So I want to have time for discussion, but in general, by sharing all those different experiences, things that worked, that didn't work, I didn't come in with a plan to do all of those things, but over time, as needs arose and partners said, I see this problem, come up with a solution and find a way to make it happen. So I just encourage everybody that over time you can build on your ideas and interests, and talking with people, legislators and lobbyists, they're not scary people. You do get used to it. And they can be good partners. It's a process that comes with practice and familiarity. So I'll stop there and see what I can help people with questions. Click the stop share button. There we go. Right, I see there were comments in the chat about how there are many different parallels to the care access situation in Mexico. Yes, I think it's a Western state thing to be. There's population centers and then there's the rural areas, and it's there are different care systems for your population center versus the rural area. And when we were doing our PAL program and doing all these educational events, I think we were about 6 or 7 years into it before we hosted any in the Seattle area. Everything else was going out in the community. So we were going to very rural areas, going to Walla Walla, Spokane, and Wenatchee, that's where we would get out in the community because Seattle needed it a whole lot less than the rest of the state did.
Thanks.
Oh, sorry, Amy. Go ahead.
Go for it, Jennifer.
All right. Hi, Dr. Hilt. My name
Hi.
is Jennifer Crawford. I'm a clinical psychologist. I hear you about the difficulty recruiting us. I work in the perinatal mental health team in our department, and we've recently submitted a grant for a reproductive psychiatry and perinatal mental health access line. We have no idea if we'll get funded, right? But thank you so much for sharing your lessons learned. It's really helpful. I was also wondering if you have any sort of parallel relationships with access lines that are serving a slightly different or completely different population, and that there's some, sharing of resources or advocacy, that kind of thing.
So actually, locally, just at the University of Washington, so there is, because of the overall success and the fact that our legislature likes it, there is an adult consult line called PCL, psychiatric consultation line. Through individual donor grant, there was a maternal mental health consult service that got started. It got changed and adapted over time based on what we had already been doing with PAL and sort of the consult line. And so it took on a different flavor over time. And so it was for a while, it was named PAL for Moms, but operated separately. And there's some unique politics here. So Seattle Children's is a different hospital, a couple miles down the road from the University of Washington and University of Washington Hospital. All the docs at Seattle Children's are faculty, but it's sort of like different institutions. So anyway, so the University of Washington's programs are actually physically separate from Seattle Children's PAL related services, and I advocated for some joining early on, and there's institutional stuff where no. It didn't happen. So they are operated separately. We used to do a lot of conversations to try to merge it, and it's like, okay, you guys can just go your own way.
Thank you. I appreciate your candor about the pragmatics of those kinds of things. Thanks, Dr. Hilt.
Yeah, yeah.
I might just actually jump into Dr. Hill. Thank you so much for the presentation. Really amazing growth evolution that you helped lead in a lot of these spaces. I was just wondering from an angle of sort of medical psych. I think in New Mexico, when we have kids in rural areas who are struggling with eating disorders, often I think we feel like I think that can feel like a tough circumstance to get kids adequate support. And yeah, I think primary care physicians sometimes feel like also, kind of where do I turn in terms of helping them and their families? So just was curious if you have anything you might share in that space from your work.
Yes, and so there's there's gradations of the eating disorders. There's those that are like so ill, it's like, okay, they got to go somewhere now. And those that are, where you're hoping to intervene earlier than that. So for instance, on a PAL consult call with a provider who's in rural area and they don't have necessarily the specialists locally, I'll say, well, making sure you can try to get them to a nutritionist with some experience with eating disorder. That can be your partner that might be more locally available. And so we'll encourage very specifically that. And they're, we'll try to connect with the best available support resources, but I'll coach about, approaches to family and the family has to ultimately learn different ways to approach food and meal times as what seems to be the most, accepted thing that works. So, to coach a family through meal support and having a different approach to food, you really should get to somebody who knows what they're doing in that arena. We'll also recommend families, check out books. So we have like a list of resources for families of books so they can do some of this learning on their own. But we cobble together the best we can, essentially.
Thank you.
Thanks so much. Again, this is an amazing talk, and I really respect all of your work and the fact that so much of it is available on the website. I've used some of the FAST materials with my own patients and some, for lots of pediatricians and the residents here to those materials as well. I wanted to ask, just with the number of, rural versus not as rural, but one of the differences are so often it's a family practice provider versus a pediatrician, and advanced practice providers versus docs. So what are your tips on bringing, non-pediatricians into the fold and having some building confidence with pediatric mental health in that area?
I don't actually view it as a huge split between pediatrician versus family practice, because there's some family physicians that are just fantastic at working with kids and families, and some pediatricians that are basically just learned the lesson of how to be a hospitalist and not necessarily the greatest with families. As honest, having gone through pediatrics residency, that's what you get trained to do, is you get trained to be a hospitalist, in my opinion, and you learn your community care on the side. But it's always in a telephone consult. It's a very quick back and forth of like, where are you at, and how can we help you? Because the advice is of care advice is very provider specific, and we'll have I'll just use the example of medications. A provider calls and said, I've tried this, I've tried this, I've tried this, I've tried this, I've tried this. And they're talking about all these sophisticated, rationales and the like. And then you have somebody's like, I have never prescribed a mental health medicine in my life. What's this whole, how do you actually start a stimulant? All that, so you have to level set, where are you at and what are you looking for? And checking in, in a 15-minute call skillfully, what's the thing that's really going to help move the care of the patient forward. So I don't view it necessarily as a profession by profession thing too much. It's where is that individual at? I see somebody typed which website. Let me type. I had it on that final slide. Let me type Seattle. How about that? for the website?
Thank you.
There were a couple other questions in the chat. Two of the residents asked about your impressive leadership experience and what are your biggest takeaways in leading people and making teams?
I think, I've mentioned how I have to try to get psychiatrists all on the same page of getting consistent advice. Some of that is hiring, good people, but then you got to talk to each other. It was easier, honestly, for us to do the level setting pre-pandemic because we had an office that was our PAL office where we all would on our work days be together and we could have lots of side conversations, which was particularly helpful in sort of the development of these programs, like, yeah, this isn't working great, or how about if we tweak that? Da, 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 da. Things have gotten fairly evolved and stable, and so we don't have to do as much programs things for the psychiatrist perspective as we once did. But now because our teams essentially work from home now. And it's stayed on that way since the pandemic. So we have team huddles and scheduled. I have scheduled consultant team chats where I talk to everybody on their days, and we do group chats on their days to talk with each other about we do quarterly fidelity audits where we review each other's work and then pull lessons out of it and discuss it on a monthly basis as a routine. So there's institutional ways where you can do this, but it's not wildly different from just that respect for persons and let's talk. See if there's something else.
Somebody with an iPhone with a hand up. I'm not sure if you want to.
Oh, yeah, I see that.
Hi, this is Paula Hensley. I'm sorry, my internet's a little unstable, so I'm not able to do the video. But so I'm actually in geriatric psychiatry, and before returning to clinical practice, I worked for an insurance company, and we administered behavioral health for one of our, statewide providers on mostly Medicaid. And what I noticed was that, in the state of New Mexico, we have a lot of RTCs that have been, shut down by the state. And so we were sending kids out of state, mostly to Texas. And what I noticed was that we were very underutilized for treatment foster care. So we were only had about 10% of the expected for the population. And we were a little over on RTC and, ended up sending kids out of state who had attachment issues and reactive attachment, really suboptimal for families.
Yes.
And so, yeah, and, the Medicaid would actually send the families out to these centers to do family therapy, but they really it would have been much better for them to be in their community. So I'm just wondering in Washington whether you all were able to kind of beef up the treatment foster care system or, what the utilization was, just because at the beginning you mentioned kids going out of state and, not being the best option for kids.
Well, yeah, and because I work with multiple states, there's very different experiences that are very state specific. So our foster care consult program was for Wyoming, and Wyoming's a very different state than Washington. Now, in Wyoming, the threshold to admit to a psychiatric residential treatment facility, I would say, is fairly low. In Washington state, there's 2 residential treatment facilities the state will admit to, and there's a whole different process. It's really hard to get in. And so the threshold is different in those 2 states. There's also different community services that are available in the states, and a lot of these communities the kids are from in Wyoming, they don't have a street light in this town, or they have, one of the last consults I did said, well, this kid is only going to be appropriate for a male therapist. Because he says insulting things to every female, and there's only one male therapist in the area, and he's booked out until for the next 4 to 6 months. So there is no local therapist option. So there's all these realities that you run into, and I think you said treatment foster care. So therapeutic foster care is a very specific thing that I'd been a real big advocate for. Washington State's way they have not valued that. And there's a different, in state of Wyoming, they offer support for their foster families, but not lots of TFC. That's one of the great ways of supporting kids in the community is do things like therapeutic foster care. Yeah.
Just to add on, from local Harrison Grace Child Psychiatry Fellow, yeah, definitely agree that more access to that would be great. I wonder too how much is availability of treatment foster families and trained therapeutic families, but
Yeah.
totally.
I mean, that's one of the availability things. They have to be reimbursed and to do this, and they have to not have a bunch of other high needs kids. And a lot of these homes will have, you can't pack a ton of high needs kids into a single family, foster family, and expect it to go well.
Totally. I have a feeling that answers to many of my questions come down to that of yes, money and resources.
Yes.
Unfortunately. So that might be something I send a follow-up email to you about your experiences with. I'm very curious about.
Foster
Yeah.
care divisions are fairly insular. They don't share a lot of information out and like to have their own solutions come from within. So that's another kind of generalization I think is helpful as you're approaching the realm.
Oh, and to tack on to that other prior question about, recognizing your leadership and asking about that, also want to recognize your perseverance and ask about that of how, going through coming to a new state and developing these things. I'm sure it was not an overnight process. How to manage, a career, running a practice, or all the other things while at the same time coordinating with legislators and administrators, etc.
It takes a lot of time and perseverance to build stuff like this. And if you don't have some time available to do it, it doesn't really click. The flip side is I hear in a lot of academic environments, just give me more time, give me unscheduled time, and then I can fulfill these things. And that alone isn't something you can count on. I was doing this in the interstices of my life to get the PAL program off the ground. And once I had some more admin time available because I was running the PAL program, then I could, okay, let's spend some more time on these other things.
Totally. Thank you.
Mm-hmm.
Thanks so much, Dr. Hill. Great talk.